everyone. Today, we're going to discuss the SAQ questions on Tiva and TCI that I've already shared in the group. So today's menu, we're going to talk about Tiva versus TCI. Usually the questions in SAQ or Viva will start off with the definitions of Tiva versus TCI. So they want to know whether you understand what is the concept of Tiva versus the TCI. We're going to have a quick overview on the principles related to this Tiva and TCI and pharmacokinetic modeling and how the questions are asked based on this pharmacokinetic modeling. And we go to the questions. So this is just overview on how Tiva is being done. First, before you start Tiva, you must have the knowledge on the drugs that are being used, to the pharmacology knowledge, the PK and PD of the drugs. Then you want to know about the pharmacokinetic modeling, so you can choose the right PK model for the TCI of that drug. And then you need to know about the patients, as usual, the pre-op assessment and so. And then you need to know about the safety during Tiva, which includes the monitoring and also the other drugs and adjuncts that need to be used for a successful Tiva. So what happens is this is the machine that incorporates algorithms and TCI modeling based on the drugs pharmacology, which is already inside the tube. So the anesthetist selects a target concentration which reaches the patient. Anesthetist selects a target concentration which goes to the microprocessor with the pharmacokinetic program which has been selected with the patient data. Then the infusion pump gives the drug into the patient, and the patient's plasma concentration, everything will be recorded again in the machine, and the anesthetist adjusts the dose based on the patient's vitals and also the patient's clinical parameters. So what is Tiva and TCI? The definition will start off. This is the question that you get in your SAQ for maybe for 0.5 mark each, 0.5, 0.5, or in Viva. Before the examiner go into the depth of this question, they will just ask of this, because a lot of people doesn't understand actually what is it. They just think TCI and Tiva is the same. So you need to understand Tiva is a method of anesthesia delivery. Okay, you have inhalational anesthesia, you have intravenous anesthesia. You can do a total inhalational anesthesia, you can do a total intravenous anesthesia, or you can do a combined CIVA, they call it CIVA, combined intravenous anesthesia or partial intravenous, whatever it means. You might use like Remi fentanyl as the infusion using a TCI, whereas instead of Propofol, you're still using sevoflurane. Okay, that is considered partial or combined anesthesia delivery. So Tiva is a method of anesthesia delivery. We have different type of anesthetic agent. We have inhalational anesthetic agent, we have intravenous anesthetic agent. If you're only using intravenous anesthetic agent for that particular case, that will be called as total intravenous anesthesia, delivered solely by the intravenous route, generally administered as a continuous infusion. That's why I use the word generally. When we begin Tiva, it was given as boluses, then it's intermittent boluses, or after that bolus continued by the infusion. But now we have the technology, we have the pharmacokinetic modeling incorporated in the pumps, which give a specific target concentration, so which use a continuous infusion. Infusion can be either run at a specific rate, mils per hour, which was in the early days, or titrated to achieve a specific concentration by running a target control infusion, which is TCI. So TCI is a technique of IV anesthesia delivery. Okay, so Tiva is the method of anesthesia delivery, whereas TCI, target control infusion, is a technique to deliver the IV anesthesia. Okay, it's a technique to deliver the IV anesthesia. The technique can be, as I mentioned, can be intermittent boluses, bolus continued by a specific rate infusion, or it can be a specific concentration infusion using a target control infusion. An infusion system where the drug is delivered to achieve target concentration in plasma or the effect site. The target can be in the plasma, or your target can be the brain, which is the effect site. Okay, operate based on various pharmacokinetic models. Examples of pharmacokinetic models, we will go into like Marsh, Schneider, Ellevel, and everything. So I hope this is clear. So before I go into the next few slides, my discussion today will be based on conventional Tiva. Means conventional Tiva means how you have been taught as a beginner and what you need to know for the basic level. Because from where the Tiva has been introduced, and when I started to learn Tiva around 10 years ago until now, it has evolved massively. Okay, the pharmacokinetic model has been improved tremendously. The way we do it, the way they improvise the Tiva method, we have multiple adjuncts, multiple combination of drugs, which call cocktails and everything. So it become more complicated and confusing, and it has been tailored for each patients and everything. Early days, we learned that MASH is only for plasma and Schneider is for effect, but now no more. It all has been incorporated in multiple way, where you can see here for Propofol, what we know earlier is MASH and Schneider for adult, MASH for plasma, Schneider for effect, Kataria and Pete Foster for the pediatric side. But now we have LFL, which is a new mode of Propofol system, Propofol TCI system, and Cortines as well, which Cortines we don't see in Malaysia, but we have LFL. For in Malaysia, I don't know whether some hospital, as far as I encountered before, we only use Remi fentanyl for the opioid TCI. We don't use sulfentanyl, L-fentanyl. So Remi fentanyl will still sticking into Minto. Okay. So as I mentioned earlier, previously we thought MASH is only for plasma, Schneider for effect, but now the current new pumps, you can even choose MASH and you can choose effect site. You can choose Schneider, you can choose plasma site. Okay, but for PEDS, Kataria and PED fusers, still plasma. We are not targeting effect site. Minto, yes, previously it was thought to be effect site. Even Minto, you can choose plasma. As I told you all earlier, for exam purpose, only think about conventional Tiva. This slide just to tell you what you do in day-to-day might be different and what you're going to answer in exam. But just have an idea in case you are doing well in Viva. If they ask you about MASH, can it deliver effect site? Yes, the new pumps can do that. Okay, and the age has been, last time there was an age limit. The important thing you need to see here is for the Propofol, they didn't mention the LFL. Okay, LFL is not mentioned here. LFL is a new and recent, more comprehensive PK model. We'll look into it in a while. So this is the basic 3-compartment model in a picturized form, where you have a first compartment where the drug is being injected into. From the first compartment, it goes to the 2 peripheral compartment 2 and 3. And from the first compartment, it goes to your effect site as well, which is the brain. Okay. So this is without the rate constant. The arrows here will have some rate constants, and this arrow down here is the elimination. So this is what you're supposed to know and what you're supposed to able to draw in a simplified schematic diagram. You don't need to draw a brain here. You can just write effect site and write their brain. Okay, so this is the drug input, drug being infused or injected, either by infusion or bolus, doesn't matter. So it goes to a central compartment. Central compartment is a blood-rich compartment. Okay, a central compartment is your blood. Okay, it goes into your blood. Then we have your 2 peripheral compartments. One is the fast equilibrating compartment. Then we have another compartment which is V3. So usually V1, V2, V3. Yeah? V3 is a slow equilibrating compartment. So fast equilibrating compartment and slow equilibrating compartment. And from the central compartment, the drug will go to the effect site. And from the central compartment as well, the drug will be eliminated. So these are the constants that you have to know. From the central compartment, V1 to V2, the rate constants are called K12 when it goes this way, and back way will be K21. From the central compartment to the slow equilibrating compartment is K31 and K13. Okay, the small numbers mean it from the central is going to the peripheral. The bigger number from peripheral is coming back to central compartment. This is the redistribution we are talking about. Okay, and then from the central compartment, a certain fraction of the drug will be always metabolized and eliminated from the body. That will be the K10. From the central compartment, there will be equilibration with the effect site as well, which is KEO. E stands for effect. The KEO will be the equilibration with the effect site. Okay. There will be a lot of pictures, a lot of schematic diagram in online and book. Choose whichever is easier for you and whichever you want to label it and everything. Okay. As you see a lot of FAQs, the answers are overlapping. So my answers also will be overlapping as well. We'll go one by one. So this is just an explanation. This is, you are injecting a Propofol single bolus doses. Let's say you want to anesthetize a young female for an appendectomy. You planning to do a conventional way of inducing with the intravenous drug and then maintain it with inhalational. You are taking a 50 kg lady, you're going to take 120 mg, 130 mg propofol, you just give me a single bolus. So what happens? This is the point of injection. There'll be steep rise in the propofol plasma concentration. This is a plasma concentration. And then since you only give a single bolus, over the time, the blood concentration of propofol will come down. Actually, there will be another graph for redistribution. We will look into it later. This is just for the introduction. So this is what happened in a single bolus dose. There will be a steep increase in the plasma concentration within a very short period. And then since there is no second or third boluses, the drug will steeply come down. This is the exponential decline. So next, we look at, you give a single bolus. This is the same as here, single bolus. And then after some time, let's say you induce this patient, initially you only give 100 mg of propofol. When you want to intubate or you're trying to hold mask or you give a jaw thrust, patient moving. So this is the time you know the propofol coming down. You give another bolus. So what happens? And then you start an infusion. You think this patient, I'm going to give a bolus of propofol manually and then you start the infusion propofol. So this is what happened. The sudden steep, when it comes down, then you start your constant infusion propofol at a specific rate. Okay, this is the difference between single bolus and no further infusion. This is single bolus, then continued by the infusion. And finally, we use the target control infusion or continuous infusion. What happens is, based on the pharmacokinetic model you're choosing, the rise will be either steep or slow, but there'll be a gradual increase in the plasma concentration and then it will be continued. This also you can use it as a model in your ICU. Let's say you have a patient in ICU, you need to sedate, you're starting a propofol at 5 ml or 10 ml per hour. So this is what happens. It takes quite some time before the propofol reaches a steady state plasma concentration, which is called the SSPC, steady state plasma concentration. It takes time. So this is the difference between a single bolus, then starting infusion and starting infusion from beginning. This part, the earlier part, the beginning part in TCI will differ. Either we are choosing what kind of pharmacokinetic model. It could be a steep rise or it could be a gradual rise. So next, what is the meaning of choosing target site, whether we want to choose a plasma or effect? Again, what I'm telling you is the conventional Tiva method. It was thought that plasma has some pros and cons and effect and pros and cons, but currently, as I told you, the pumps have evolved. Even plasma, you can adjust it, the time and everything to mitigate whatever the cons they have last time, and also it goes to the effect. Okay, so we have plasma and effect. Let's say we are choosing a pharmacokinetic model that targets plasma as the effect site. Okay, sorry, the plasma as the target site. Okay, so what happens is, you see CP mean concentration in plasma, CE mean concentration in effect. Our effect site, let's say you are giving propofol, is the brain. Okay, so what we want to know, our effect site is the brain, how fast the drug reaches from the blood to the brain. So if you use plasma as your target site, the pump is pumping the blood mainly into your V1. So CP increases quickly to reach the target concentration. Your steady state plasma concentration reaches very fast. Okay, you see the steep concentration, but the CE goes up relatively slow because from the V1, it has to go redistribution. Okay, it has to go redistribution to reach the effect site. So in this case, you will see the slow induction. If you see a plasma as a target, then you can see your induction will be slower. Patient will lose consciousness slower. But it is a smooth induction and maintenance. Since no large boluses of drugs are being infused very fast, there will be a less fluctuation in your hemodynamics. So it's a smooth induction and maintenance, and it's a fast recovery. Conventionally, it was taught to us that it is suitable for children, old age, weak patient, and poor heart. In comparison with effect site, where our target is effect, you want the patient to sleep fast, immediate propofol reaching the brain. So what happens is, you can see the CP, of course, will be a surge because anyway the drug has to reach the blood first, the plasma first, before it can before it can equilibrate with your brain. But in this, there will be a sudden boluses of your propofol more than your plasma side So the equilibration between the concentration gradient between your plasma and brain is bigger, and there'll be a faster equilibration from your blood to the brain, and the CE concentration will reach faster than the plasma as your target site. You can see CE increase quickly to reach the target concentration, CE here, whereas CE takes longer, whereas CE reaches fast. Obvious overshooting of CP. The plasma concentration, of course, will overshoot because they want to create a larger gradient between the blood and the brain. Drug effect appears quickly. Patient lose consciousness fast. It's a fast induction. The overshooting of CP may cause breathing suppression. So this is breathing suppression, and also about the hemodynamic fluctuation, because there's large amount of blood propofol is going into your hemodynamics. Okay, so it does not only go to the brain, it also goes to the other part of your body, your heart and everything. So in patients who have a poor heart, or young patient, patient who are poor heart, or patient with unstable hemodynamic, this is not so ideal. So it is more suitable for young patients, strong patient, mean ASA 1 patient lah. Again, remember, this is the conventional way of we are learning. Currently, this all can be modified. Even choosing effect site, we can time our induction so we can have a smooth induction, okay, but relatively faster. So all this, for exam purpose, we learn it from the traditional way. So now we are going into the SAQ. Whenever I discuss SAQ with my students, my first opening statement is this. Are you trying to give your best answer in SAQ, or are you trying to give your practical answer in SAQ? Best answer means you're trying to aim 9 out of 10, 10 out of 10. But you have to know your level. You have to, at your own, you have to assess your capacity. Am I potential to write this much of information within the 20 minutes to gain that much of marks? Or are you able to? So what you have to do is you have to come up with a practical answer to gain the most marks within the 20 minutes for that relevant question. So this is how you prepare yourself. Of course, within the 20 minutes, sometimes the input that you're given is not enough to gain 9 or 10, but you will at least achieve 6 or 7 or 8, which is the passing mark. But this is what I'm talking about, practical. But of course, if you are a good student, you are a brilliant student, of course, aim for the 9 or 10, if you can reproduce it within the 20 minutes. So my answers are practical answer, not best answer. I'm aiming for the practical answer, which 90% of the students should be able to reproduce within the 20 minutes. Okay. So the questions that I gave it to you is I made up myself. Okay. I just made up myself for you to just have a discussion, for us to just understand how this question can be asked. From the question, we try to learn something. But the last two questions I took from past year, which is, I think one is from 2020, another one is even more earlier than that. Okay, first, outline the properties of propofol that makes it an ideal agent for TCI or Tiva. So this one purely asking you about pharmacology of propofol that makes it an ideal agent for TCI Tiva. It can be asked in SAQ, it can be in also SBA also can come out of it, or it Viva, if there is a Tiva question, TCI question, there will be a pharmacology question on propofol for Remi or remifentanil for sure. So this is my practical answer for 3 marks. Thinking each of the point will carry 0.5 or 0.25 marks. Most of it will carry 0.5. So what I divide it into. My answers are based on PK/PD of the drug, but it's more into PD because we are using in Tiva, the outcome. So I'm relating my answer to PK, pharmacokinetic properties of the drug, which influence the pharmacodynamic of the drug. Okay, so propofol has rapid onset. It induces anesthesia within 30 to 40 seconds. This is the pharmacodynamic effect of the propofol. Because why? It has this pharmacokinetic property due to its high solubility and rapid crossing of the blood-brain barrier. So that is the rapid onset, which is good as an ideal agent for Tiva. Rapid distribution. Propofol has large volume of distribution, which is almost 2 to 10 liters per kilogram. So why is it important? It has short effect equilibration time, which is KEO, the rate constant, approximately 1 to 3 minutes, which is crucial for achieving stable plasma and effect site concentration. Again, going back to rapid onset and also achieving the steady state plasma concentration or steady state effect site concentration in a fast manner by using 3-compartment pharmacokinetic models. You have to put this because Propofol in TCI or Tiva is used based on 3-compartment pharmacokinetic modeling. And then Propofol has a rapid offset because of its pharmacokinetic properties of high clearance rate of 1.5 to 2 liter per minute, rapid elimination from the body. These are all my own answer. As I say, it might not be the best answer. I am answering which is practical. You take it and you can modify it, you can enhance it. Okay. You don't have to write in essay or paragraph. You can put it in point form like that. For sure, it can be done. Okay, and it's acceptable. Next, we are talking about duration of action. Effects of a single bolus dose typically last 5 to 10 minutes. Precise control over anesthetic depth. The contact sensitivity half-time. Of course, contact sensitivity half-time you have to write in full. First, I'm making it short for the slide purpose. You have to write at least once in a full term. In bracket, you can write the short form. Contact sensitivity half-time remain relatively short even after prolonged infusion, making it suitable for TCI or Tiva. And then you mentioned the duration. TCI after a 3-hour infusion for Propofol is around 40 minutes. Okay, but you can look into it again. This value might be wrong. I think it's not 40 minutes. I think I made a mistake here. This is not for 40 minutes. It's for 8-hour infusion. Okay, and then of course, Propofol also has inherent anti-emetic effect, reducing the incidence of PONV, making it an added feature to be used in a Tiva. Or it is bringing an extra added benefit comparing to the inhalational anesthesia. So it is, of course, we don't want post-op nausea, vomiting in any patient, but by using Propofol here, one is used as an induction agent and maintenance agent. On top of it, it has an inherent anti-emetic effects. So that's for Propofol. Okay, the second question is about remifentanil, but I'm going to finish off all the induction agent and pharmacokinetic modeling for Propofol first, then we go into remifentanil. So the second question I'll discuss later. Okay, so number 3, we are going to talk about why midazolam is not a good ideal agent. Okay, not a very good agent for TCI or Tiva. So again, the answer is based on pharmacokinetic and pharmacodynamic. It has a delayed onset. You can see my answers are almost similar template. Okay, I'm just making a similar template using the same concept. Slower onset of action compared to agents like Propofol, taking several minutes to achieve peak effect. Delayed offset can result in prolonged sedation and difficulty in titrating depth of anesthesia accurately. Okay, and it has a prolonged contact sensitivity half-time. The contact sensitivity half-time increases linearly with the duration of infusion. This can lead to delayed recovery, prolonged sedation, making it less suitable for precise control in TCI or Tiva. Then you have to mention about the metabolites, which can cause this accumulation and cause this post-infusion effect, which is due to its longer half-life and potential for accumulation, especially in prolonged infusion. Metabolized in the liver by cytochrome P450 enzyme, particularly CYP3A4, if you can remember this. The metabolism is highly variable among patients due to genetic differences and interaction and with other drugs, and leading to unpredictable pharmacokinetics. Okay, this is my way of answering for midazolam why it's not a better agent. Of course, you can enhance it, putting it the exact duration of the contact sensitivity half-time. You can mention the exact TF, elimination half-life of these drugs and everything. Okay, what I'm doing you is I'm giving you an idea how to answer SAQ and giving a little bit of answer, practical answer. What I want you to do is you have to put in your own effort to make it your template. This is my template, my way of answering. You have to make it better by making it your template, your way of answering. Next, the question should be why remifentanil was a better drug, but now we are going, we will look into it later. So now we first look into why morphine is not an ideal agent for TCI Tiva. So this question can be morphine, can be fentanyl, it can be tramadol, whatever. Okay, so now I just chose just for question's sake and discussion, I chose morphine. Again, the answer will be somewhat similar to Mida. Okay, slower onset of action compared to remifentanil, taking about 5 to 10 minutes to achieve peak effect. delayed offset, prolonged effects, and difficulty in titrating, the same like Mida. Long elimination half-life, relatively long elimination half-life up to 2 to 4 hours, lead to prolonged sedation and delayed recovery, difficult to achieve precise control, and accumulation again because of its active metabolites, metabolized in the liver to active metals such as morphine 6 glucuronide, which can accumulate, especially in patients with renal impairment, especially with continuous infusions. So can result in prolonged sedation, respiratory depression, making it less suitable for TCI or Tiva. So this is, you can see, the concept are the same. I'm just picking the answer, some answer which is specific to morphine and putting it in. Okay. These are the questions that you can mostly get it Viva. They just want to see whether you understand or not. Why did we go to remifentanil rather than morphine? So this how they want to incorporate your pharmacology knowledge. They want to know whether you understand your basic pharmacology of the drug or not. Okay. Next, we go into the pharmacokinetic principle and modeling of propofol. Okay, these are the most of the famous questions. This is the past year question. This is one of the past year questions. So outline the pharmacokinetic principles of Tiva using propofol. 6 marks is quite a lot of marks, you know. So you have to write quite a bit, and of course you can't miss out your diagram in this. Okay, not this diagram. This is what we show there. What you're able to draw is this diagram, and then you can write this as a V3 here. So V1, V2, and V3. This one I got it from online. So this is V3 here. And you can even write what is this central compartment. You can write there. What is the brain? Effect side is the brain. What is the peripheral compartment? Okay. And then finally your elimination. Make sure if you get a question like this, straight away draw this first and label it. Then you can explain from there that this diagram itself, if you have label it properly and draw it properly with the arrows and rate constant, should able to give you at least 1.5 to 2 marks from here itself, and label it as a 3-compartment model. Okay. Then, so what does the 3-compartment model? Central compartment represent the blood and highly perfused organ. So central compartment is the compartment where the drug is being injected, is the intravascular compartment or central compartment, and from there it can also go to highly perfused organs such as brain. Okay, so this is your first compartment, and you have your rapidly equilibrating compartment. V2 represents the well perfused tissues like muscle, so which is this. Your fast equilibrating compartment, and it's a small compartment compared to a V3. This is V3 here. Peripheral compartment with the fast equilibrating compartment, and we have a slow equilibrating compartment V3. This is V3, which is represent poorly perfused tissues like fat, but they encompasses a larger mass, okay, larger volume, okay, compared to the V2. Okay, what happened in central compartment? Initial distribution. After administration, after you inject propofol, the propofol rapidly distributes. Okay, we are talking, the question is in Tiva, not in a single bolus. Pharmacokinetic principles of Tiva using propofol. Okay, so what happens? Initial distribution, after administration, propofol rapidly distribute into the central compartment, which includes the blood and highly perfused organs like the brain. So V1 is initially the blood and immediately to the effect site, where here is the brain. This rapid distribution accounts for the quick onset of anesthesia because your drug goes to the central compartment and highly perfused organ first, in which is the brain and which is our main target, where effect site for loss of consciousness. And then you must know the rate constant K10 represents the clearance of the drug from the central compartment. And you see, this is the drug being input. From here, a certain amount of drug is being constantly eliminated, where this equilibration between the V2 and V3 also occurring at simultaneously. All these are occurring simultaneously, okay, but at a different rate. That's why we have a different rate constant, K12, K21, and so. So rapid equilibrating compartment V2, where your redistribution phase occurs, this part, K12 and K21. Propofol then redistribute from the central compartment to the rapidly equilibrating compartment, which includes well-perfused tissues and such as muscle. That's why I'm saying here, if you draw this, you can here itself, you can write central compartment, blood, brain, peripheral compartment, fast, small, you can write here tissue, muscle, and here you can write fat. So you don't have to keep writing it here again. Okay. Rate constant 12, K12 and 21 describe the transfer rate between the central compartment and the rapidly equaling compartment. Since you have already labeled here rapidly equilibrium compartment V2, slowly V3. You can just write here V1, V2. You don't have to keep writing again central, central, central. I'm just showing you. Okay? If you see in my next answer, I wouldn't have been repeating this central. I would have said say V1, V2, V3. So at once you have already write and you have mentioned here, you can just use that short form here. Okay. Next, slowly equilibrating compartment. The drug further redistributes to the slowly equilibrating compartment, which include poorly perfused tissues like fat, which is here, but encompasses a larger volume. Rate constant K13 and 31 describe the transfer rates between the central compartment. You see, by drawing here, drawing these as complete and labeling it properly, you can actually cut down your writing to almost 50%. And so that is reproducible within 20 minutes. Okay, and it is self-explanatory. When the examiner is reading your answer, they know what you're talking about. Okay, understand? So now just to supplement or end it, because the question asked of principles of Tiva using Propofol, you're going to talk about the application in TCI. You already explained the pharmacokinetic principles, but you want to mention how this principle being applied in TCI or Tiva. You want to talk about effect site equilibration, where this is the part that we are interested in, KEO. Because you see here, I haven't mentioned about KEO yet. So in TCI, the goal is to achieve and maintain target effect site concentration. The rate constant KEO describes the equilibration between the plasma and the effect site, this part. Okay, so you see this one is a better diagram. V1 central compartment, you can write here blood, and here you can write brain. Then you can write rapidly equilibrating compartment V2 muscle, K12 and K21. Then slowly equilibrating compartment, which is fat, you can K13 and 31. K10 is the constant elimination or metabolism from the central compartment, and from the central compartment effect site there will be a constant equilibration. Okay, describe the equilibration between the plasma and the effect site, which is the brain. Propofol has a short effect site equilibrium time. It means from central to effect it is very fast, allowing for rapid adjustment in anesthetic depth for you to offset and onset and offset. Let's say central compartment has a higher volume of Propofol, it will larger gradient, it will go to brain very fast. Let's say you off the Propofol infusion, central compartment concentration drops, the effect site drop will also, because then effect site will be higher, central will be low, there will be re-equilibration, there will be redistribution from effect to central, and patient will wake up. So that's what allowing for rapid adjustment in anesthetic depth. Hope this is clear. Okay. Next, we go to questions which are more applied and more going to like a conclusion kind of question. This is asked in the final as well. So you have to know at least basic advantages of Tiva. We are not talking about paragraphs and paragraphs. We're going to put it in point form. 3 marks, I will say it's 0.5 marks per point. So you take it as a 6 points. Okay. So these are the well-established, evidence-based advantages of Tiva over inhalational anesthesia. We are talking about Tiva versus complete inhalational anesthesia. Number 1, recommendation 1, grade 1 evidence is reduce post-operative nausea and vomiting, especially with Propofol. Significantly lowers, p-value is less than 0.05. Significantly lowers the incidence of PONV, enhancing patient comfort and recovery. If they are just ask you to list, you don't have to explain this. If they ask you to outline, just give a bit of explanation like this, which is more than enough. Quicker recovery. Patients generally experience faster and smoother recovery with Tiva, as it allows for precise control over anesthetic depth and rapid emergence from anesthesia. Improved quality of recovery. These are two different things, in quicker and improve. Improved quality of recovery, better overall and recovery quality, including reduced emergence delirium and less airway reactivity. It means after extubation, there are less incidence of spasm, leading to fewer complications post-surgery. Enhanced neurophysiological monitoring, especially in neuro or spine cases, where you can induce and maintain anesthesia without muscle relaxation. Okay. So Tiva facilitates better neurophysiological monitoring during surgery, such as spinal instrumentation, as it avoids the interference caused by the inhalational agent. As your SSEP monitoring or MEP monitoring, SSEP monitoring is affected by your volatile, your MEP monitoring is affected by your muscle relaxant. By using a Propofol, Remi, fentanyl, Tiva, you can actually avoid the use of these two. Let me start again. So we already talked about improved quality of recovery. We talked about enhanced neurophysiological monitoring, where we can avoid use of volatile or muscle relaxants, so we can do SSEP or MEP monitoring. Next is reduced airway reactivity. Reduced airway reactivity is Tiva reduces the risk of airway reactivity. This is not after post-op. This is intraoperatively as well. It is proven then with a patient with the airway reactivity, or patient with the airway disease, or patient with the recent URTI, this patient with a asthmatic or anything, there are less complication or airway complication when we use Tiva compared to inhalational, making it safer for patients with reactive airway diseases. Less operating room pollution. This is also a great one, which is well established. This is a debate that's going on about the Tiva over inhalational. Tiva eliminate the use of volatile anesthetic gases, reducing environmental pollution and exposure of alcohol vehicles to anesthetic gases. This is your global warming and so on, so on. So these are the 6 evidence-based established advantages of Tiva, which is more than enough for you to get 3 marks. Okay. And these are this more elaborative answer for advantages of Tiva based on system by system and in certain surgeries and so on. I'm not going to go into the depth. This is more for finals, okay? More for finals. So I will just share the slides later. Maybe you all can look at it. It's actually reduce inflammation. It reduces your SIRS and so on and so on. So we will go into this. We're not going to go into the depth of it. Briefly describe the PK model used in TCI. What variables are used in calculating the loading and maintenance dose in TCI? So these are kind of specific questions, okay? So we're going to choose few pharmacokinetic models. We're going to talk about it. And then what are the variables that you have to input? We have to key in into the pump for each of these pharmacokinetic models, okay? But I'm not going to go into the fine details about it. So when these questions come, you have to somewhat mention about the formula for loading dose and maintenance dose. I didn't put it in here. That's your homework. So this question, they mention about loading dose and maintenance dose. So you have to mention the pharmacological formula, how we calculate loading dose and how we calculate maintenance dose. That will be your introduction, okay, before we actually talk about the pharmacokinetic models and the variables. So I made a kind of comparison here, okay, just to show you all. For this question, you're going to talk about this. These are the key features, okay. This description is just a prelude or introduction. And the second part of the question, the variables, are what I'm going to answer here. So if I get this question, I will answer in a table form, okay. But how many models you want to choose, up to you. You can choose 2 models, 3 models. And as I said, if you ask me, is this a practical answer? No. Am I able to reproduce this in 20 minutes? I won't be able to reproduce, but I just want to show you what are the answers that you can write. You may choose 2 model or 3 model. You can just choose 1 MASH and 1 Minto to show different drugs or so and so. Okay, it's a 6 marks question. So I don't think, and it has a 2-part question as well. So I think it's a 5 marks with the 2 parts, okay? So describe the PK models used in TCI. You may start off with drawing the simple diagram and talk about the central compartment within like 1-2 sentences and go into this. I don't know that what will be the exact marking scheme, but if I get this question, how do I approach? I will just draw this, okay? I'll just draw this, okay? And then I'll just go into this kind of table form and I'll just choose 2 or 3 models and try to fill up the table as much as I can. Just for overview and introduction, MASH is the earliest and most widely used model based on a 3-compartment model fixed rate. You don't have to give this introduction. Most of the Propofol all are 3-compartment model. Just to compare for those who have not familiar with this model. Schneider is also for Propofol, but it's more into effect side initially, but now it can be used both. But what is the difference? It incorporates specific factors such as lean body mass and everything. So here it uses a total body weight. Elevel is a new and most recent and comprehensive model used across a wide range of population. Like Marsh and Schneider is only for adults. For peds, you have to use Kataria and ped fuser. But Elevel, it can be used in neonates. It can infants from 6 months up to a very old patient. And the range of height and weight, the BMI for Elevel also is very big. Okay, I think up to 150 or 250 kilo. We'll look into it later. So that is the new pharmacokinetic model, which is LFL, and Minto is mainly for your remifentanil. So the key features: MASH, it targets the central compartment in a conventional pump, which is the plasma being the target site. Volume of distribution is weight proportional because we put in a target total body weight. Clearance also weight proportional. Application used for plasma targeted CCI in a conventional Tiva. Okay, straightforward approach to dosing. Whereas in Schneider, it's more into an effect side in the conventional Tiva, where you have your V1, V13, K31. It means your slowly equilibrating component comes into picture as well. So these are fixed values. Your central component and your slowly equilibrating components are fixed, but your adjustable parameters are V2, K12, and 21, because here we're looking into lean body mass. We know V2, which is the rapidly equilibrating component, composed mainly of muscle. Okay, muscle. So here when we calculate lean body mass, so we are able to target exactly the muscle mass. So that is the adjustable parameters, adjusted for age, and K10 is adjusted for weight. K10 is your elimination, constant elimination from your central compartment, and lean body weight, lean body mass, and height. Of course, all the pump you put in age, you put in height and weight, but based on what pharmacokinetic model you choose, they will take the specific parameter they want, and then they calculate the lean body mass and everything. Application often used for effect site targeting, providing more precise control over anesthetic depth. You don't have to calculate the lean body mass, the machine will do it for you. And LFL, broad applicability, account for a wide range of physiological variation, age, height, weight, so on, so on. Dynamic adjustment, continuously adjust based on specific parameter and real-time data. So this is the most evolved pump which I have encountered, but what we have in Malaysia now, where it dynamically adjusts. It adds the patient's concentration, and we adjust the rate accordingly. It adjusts, the algorithm evolves and adjusts at the real-time data. Application provide robust and flexible dosing for diverse patient group. Minto, specially designed for remifentanil, incorporate patient-specific factors, usage and weight and gender. So effect site targeting, Minto again effect site, focus on achieving and maintaining a target effect site concentration. Adjustable parameter takes into account individual patient characteristics, optimized dosing. Application widely used for remifentanil, ensuring precise analgesic control. So as I mentioned, in conventional Tiva, where MASH is only for plasma, Schneider is only for effect, LFL is for both, Minto is only for effect. For MASH, the variables that must be key in is total body weight, is not age related. Whereas for Schneider, you need to put the age, height, lean body mass, and total body weight. Which is lean body mass, you don't need to put in, the machine will calculate. Means this lean body mass parameter will be calculated by the machine. LFL, you need to put age, weight, height, and other patient-specific factor, which is sometimes you can even put the patient's illness in some pump. So that will go with some kind of your thing. So LFL is relatively new. Even I'm learning it until now. So Minto is again age, weight, gender. But in the pump, like in a practical day-to-day application, of course, you put in age, height, weight, sex for all patients. Okay, but what the pump chooses is based on the pharmacokinetic model. So again, look into this. This is talking about, so you see that's another one and everything. So what I want you to look into this is here, this on the table, which is my arrow is showing here. You can see MASH age is 16 to under 50. Weight is 30 to under 50. Whereas LFL, the age is from 6 months to 99 years. And the weight can go down up to 1 kilo, up to 160 kilo. Okay, it's more comprehensive. Well, for Schneider, Schneider will have a cutoff in BMI when you put in. Same goes to Remi. All the effect site model, they'll have a cutoff in BMI because if you put a height and weight there, so it will have a cutoff in BMI. Because MASH, you don't need to do gender as well. It's not gender specific. Whereas for effect site, when you use Schneider and Minto, they are effect specific. You can see got a lot of other models as well, which is. So as I started off my presentation, I'm only teaching conventional Tiva. Next, using a 3-compartmental model, explain the pharmacokinetic propofol. We have mentioned it later, but now the question has 2 parts. its first part is following a single IV bolus. The next one will be following a, so we already talked about what happens in single bolus. So you inject the drug, it goes to central compartment. After that, you stop injecting. You inject and then you stop. It goes to central compartment. From there, it goes to V2, V3. Here they use compartment 1, compartment 2, compartment 3 is V1, V2, V3. And then it gets eliminated. So what happens is when you inject, shoot from the plasma, it reaches the plasma concentration steep and then come down. A rapid redistribution propofol. And then this is gradual redistribution from the peripheral compartment. And then it's getting eliminated. So initially from the plasma, this part is getting eliminated. The red line is coming down. Then from the C3 and C2, it's going back to C1 and then eliminating. That is the blue line. The gradual redistribution and elimination. So this is what happened after your single bolus. So if the question comes out like that, you have to draw this graph. You have to draw this graph to show what happens. You draw this in a squares and everything, and you draw this. This is how you start answering the question. So you're going to answer this if you haven't drawn the graph. So I'm just showing here. So what happened? After an IV bolus, propofol rapidly distribute into V1, blood and highly perfused organs like the brain. So it's the same answer what we have talked about. It's a repetition, but the question can differ slightly. Rapid distribution, quick onset of anesthesia, typically within 30 to 40 seconds. Rapidly equilibrating component, redistributing phase, propofol doesn't distribute to V1, V2, same thing. The phase is characterized by rapid decline in plasma concentration as drugs moves into the tissue. This is the rapid declination because from the V1, this is the blood. From the blood, it's going into V1 and V2. So the earlier part is V1 up to here. From V1, now it's going into V2 and V3. That's why it's dropping. As it's dropping, V1 and V2 concentration increases, and then later from V1, so V2 and V3, it goes back to V1 and get eliminated. So that is the explanation here. Slow redistribution phase, drug further redistribute V3, poorly perfused like fat. The phase is slower and continues prolonged tail of the plasma concentration curve. This is the prolonged tail of the plasma concentration curve. Clearance, propofol is metabolized primarily in the liver and excreted by the kidney. Elimination phase is characterized by slower decline in plasma concentration as the drug is cleared from the body. High clearance rate ensures that propofol does not accumulate significantly even with repeated dosing. These phases result in a tri-exponential decline in plasma concentration, reflecting the complex distribution and elimination process of propofol. That's why 3-compartment model, tri-exponential decline. From the central compartment, one decline. Then from the central, it distributes, second decline. And then after that, they come back to central compartment and eliminate another decline. So tri-exponential decline. Again, the same question. But now what happens in TCI? We talked about it earlier. So just another question. This is what I mentioned earlier. You're going to draw the same diagram. You're going to explain it in the same manner. Okay. This is purely a repetition, but this is a past year question. That's why I put it here again. Okay, this is, you're going to draw the same squares, you're going to label it with the KEO for the brain, effect site, and then you're going to write the same thing. Okay, this is what you're going to write. Again, in TCI, effect site targeting, so you're going to talk about KEO. We talked about it earlier. Exactly same answer template for this question. But here is 6 marks, so you're going to write all this, and then you're going to write this, you have to draw. Okay, 6 marks. But of course, as I mentioned, you see, if already, but you can just put V1 here, V2. So you can make it concise. You don't have to write this much words, of course. This is for teaching purpose. I put it in an elaborate form. Okay. But once you have drawn the diagram, you can make it simplified. The examiner will understand. Okay. So now we finish it off the next 15 minutes talking about remifentanil. So outline the properties of remifentanil that makes it an ideal agent for TCI Tiva. Okay. So the template is the same, just specific details regarding to the drug, typically within 1 to 2 minutes due to its high lipid solubility and fast distribution, rapid offset, rapidly metabolized for non-specific plasma and tissue ester hydrolysis. Okay, independent of liver and kidney function, extremely short elimination half-life, approximately 3 to 10 minutes because of this. Duration of action, contact sensitivity half-time remains very short even after prolonged infusion because again going back to this, the ester hydrolysis. For example, after 3-hour infusion, the contact sensitivity half-time is 3 to 4 minutes. I think after 8 hours, still just 8 minutes will come into the graph. It's a potent analgesic, potent mu-opioid receptor agonist, providing strong analgesia, highly effective in managing intraoperative pain, reducing the need for additional analgesic. If you are running a remifentanil infusion, you most of the time no need to give any other analgesic unless you are practicing multimodal analgesia. Just before waking up the patient, 30 minutes before, you're going to give morphine or you're going to give other analgesia for post-op pain. So that's why the keyword is here, intraoperative pain. Okay, and minimal accumulation due to its rapid metabolism and elimination. Remifentanil does not accumulate in the body even with prolonged infusion. It does not have any active metabolite and it rapid ester hydrolysis. This minimizes the risk of prolonged sedation, respiratory depression compared to any other opioid. So this will give you 3 marks for sure. Okay, next, a little bit tutorial on opioids in Tiva. So why we chose remifentanil compared to anything else? So you can see how do they choose, mainly based on this parameter. Okay, it has an elimination half-life of very short, 10 minutes. The clearance is the highest compared to any other opioid, and it has a very small volume of distribution. So that accounts for a rapid onset and offset as well. Okay, these are the 3 main features of remifentanil pharmacokinetic properties that makes it as an ideal agent for Tiva, which we discussed earlier. Okay, then this is a comparison I made for my class on Tiva. I think this is for Tiva workshop I made it. Again, I've mentioned it here, the VD, the TF and CSHT. I'll give this slide for your, this is if the question purely on pharmacology of opioid, compare and contrast pharmacokinetic properties of remifentanil versus alfentanil, maybe you can use this table. Okay, the metabolism you can see, other opioids are all based on liver. Okay, they depends on liver, whereas remifentanil is basically on enzyme hydrolysis. So this is what I mentioned by ester hydrolysis compared to sulfentanil, alfentanil, and fentanyl. You can see remifentanil as a ester group, which can make it undergo ester hydrolysis, ultra fast offset, and allows for rapid titration. So contact sensitive half time, this graph, of course, you have to know, you must be able to draw this. You can maybe ask to draw in the Viva as well. You can see you must be able to define contact sensitivity half time. I'm not going to go into that. Okay. So what happens is a time taken for the concentration to drop after you stopping the concentration to drop by 50% after you stop the infusion. Okay. So you can see remifentanil, even after time taken for the plasma concentration to fall by half when an infusion is stopped at steady state plasma. I mean, the drug has been running at a steady state plasma concentration infusion. You stopped it, and how long will it take for the concentration to drop by half? That is contact sensitive half time. So the remifentanil you can see is hardly, even though after like 10 hours, 600 minutes is still around 8 minutes like that only. Whereas fentanyl, you can see it linear increase. Alfentanil reaches a plateau later. Sulfentanil gradually increase. Okay. Longest possible CSHT is only 8 minutes even after 10 hours of duration of infusion. Okay. This is comparison with the Propofol included and midazolam. You can see midazolam is the one with the triangle up. So this is the midazolam. You can see it's gradually increased. Okay. After 8 hours of infusion, it can go up to 60 minutes, okay, up to 60 minutes to wake up time, where Propofol is around, I'm sure it's around 8 minutes, after 8 hour infusion, it's around 40 minutes, 30 to 40 minutes, if I'm not wrong. If after 3 hour infusion, I think it's around 20 minutes or 10 minutes. Please go and cross-check this, whereas Remi. So you can see compared to any other induction agent and opioids, Propofol and Remi as the best contact sensitivity half time, okay, making it them the ideal agent for TCI Tiva. Why Remi is good? They have studies shown remifentanil with Propofol as the better anesthetic profile. They provide the best analgesic sedation in combination. So this is by study compared to any other opioid with Propofol. So remifentanil pharmacology, I'm not going into in the depth of it. You must know how to dilute it, what is the final concentration, and so on. You must be able to mention few cautions or disadvantages or pharmacodynamic effect of Remi. It causes a dose-dependent hypotension and bradycardia. Bradycardia can be reversed with glycopyrrolate, atropine, ephedrine. This is a practical knowledge because I did a workshop, so I was telling them. Hypotension, reduce the rate of infusion or administer fluid or vasopressor, same concept what you do. Respiratory effect, depression or respiration is dose-related fashion, but very insignificant compared to any other opioid. Spontaneous respiration occurs at the dose of 4 to 5 nanogram per ml. Muscle rigidity related to dose and speed of administration. If you infuse at a high dose and a faster rate, of course, it causes chest wall rigidity as like other opioids as well. Occurs when more than 1 mic per kg is administered within less than 60 seconds. It means very high dose in a very short time. Decrease by decreasing infusion or with the muscle relaxant. Okay, this is practical aspect. Remi, in the beginning, it was given in a mass rate infusion, or even in some hospital for pediatric cases, we run Remi in mass rate infusion because Remi model Minto for peds, we don't have it yet, or it is only a very restricted population range. So its mass rate infusion is used instead of TCI. So Minto model is a 3-compartment model again, programmed to target either effect or plasma site. As I mentioned earlier, it was only told to be effect, but now it can also go for plasma. Can over predict by as much as 15%. CE rate constant, effect site rate constant, KEO, loss of constant effect derived from electroencephalogram, EEG based. Initial bolus dose delivered in CET mode 3 to 4 times greater than CPT, which we talked earlier. When you choose the effect site, the induction dose will be higher compared to the plasma being the target site. Input of agent, patient sex, age, weight, height and cm, then the machine will calculate your lean body weight, age more than 12 years and weight more than 30 kilo for you to use Minto for Remi. Okay, that's why I say in pediatric population we use mass rate infusion model. Mass rate infusion means you key in mic per kg per minute, like how you do for your noradrenaline or adrenaline. Okay, but the recent pumps, evolved pumps with the advanced pharmacokinetic model, you don't have to use mass rate infusion. You can use the TCI models. Low propofol, high remifentanil, or high propofol, low remifentanil. This is a practical effect. People go for low propofol, high remifentanil for better hemodynamic profile. Modified rapid sequence induction, you can start 4 to 6 nanogram per ml, where you can avoid sometimes even muscle relaxant. Combo with induction agent ketamine, thimetol, propofol, or succinylmetonium or rocuronium. So this is for modified rapid sequence induction. Okay. So this is mass rate infusion. You can see if you prepare in the 50 microgram per serve, so you have the weight and then how much you have to run. There are tables in the brochures and everything just for me. The regime and the remifentanil, what we use, this is a Tiva guideline. We have a Tiva guideline from Malaysia. You can go to Academy of Medicine. You can download it. So they talked about how do we go about when you use a target control infusion, constant rate infusion. Of course, this is used as just as a guide. With this, actually, we can even go lower than the dose that recommended in this guide nowadays. Okay, when you use Tiva, of course, you have a proper monitoring, and this is the guide. This is the recommended monitoring when you use Tiva, total intravenous anesthesia, to assess the anesthesia awareness. Okay, so I will come into that. I'm not going into these protocols. Okay, this is just for your showing here. You can read it on your own. Okay, I'm not running a workshop, so I'm not going into this. You see there is a Remi in obese, Remi in kids. There are precautions and what we look into it and everything. Okay. What I wanted to show you is safety consideration and monitoring requirements for Tiva. This is for practical and also can come out in your SAQ as a very short note just for complement's sake, but this is more into final. Again, I just want to show you a simple answer. If you just ask you, can you list down few safety consideration monitoring, talk about patient monitoring. So you need to have a standard monitoring and you have to have a process EEG monitoring, which is BIS or entropy, to measure the depth of anesthesia as how you use MAC for inhalation anesthesia. Equipment and setup, you must have a proper pumps, which is connected to an electrical circuit, which is running well, which has a proper modeling. Then you have the knowledge to use the what drugs and what model to use. Drugs and fluid, you must have a proper set, Tiva set, with the anti-reflux valve, so it doesn't have a backflow. You must have very good running lines, which is visible and must very label clearly, so you don't misinfuse drugs. Drug preparation and administration, again, the proper volume, proper concentration, proper dilution, aseptic technique. awareness, adequate dosing based on BIS, so you don't cause anesthesia awareness under GA, depth of anesthesia monitoring using BIS, drug interaction, what kind of drugs you want to use, if you want to use a combo drug, if you are using some other drug, whether they have any drug-drug interaction. You also need to know about patients' drug allergies and drug adverse effect from the previous general anesthesia. Pharmacokinetic model, you must have adequate knowledge regarding the models you have to use so you can tailor the dosing and minimize interaction. And finally, of course, training and competence. As I mentioned, this is more into a final. So in finals, a final year student should answer, including this training and competence, not only for the doctors, also for the staff, allied healthcare staff who prepare the pump for you, who maintain the pump for you and everything. So finally, use simulation-based training to manage potential. You must not only know how to use it, you must know also how to troubleshoot and manage the complication that could arise from running a Tiva. So guidelines from Tiva, Association of Anesthetists, SIVA. SIVA is Society for Intravenous Anesthesia. They come up with this just for your knowledge. I'm not going to discuss into it. I've talked into it in this form, the safety and consideration, but they put it in the 10 full form here. It is again knowledge, pumps, monitoring, so and so. This is using Tiva. Again, they use this concept of per use before you infuse. P stands for propofol, E stands for empty label. So make sure empty label because you want to make sure it's 10 milligram or 20 milligram per mil propofol, 1% or 2% propofol. So you don't discard it until the case finish. So if someone take over your case, let's say your propofol is not labeled, at least they're looking at the ampule, they will know what kind of concentration you're using. Remi fentanyl, again, correct dilution, user setting, what pump you're using, have you put in the right parameters of the patient, the demographic of the patient, setup, giving set, the lines, the connection, make sure there is no leak, there's no kink, the safety valve has been opened, the clamp has been open, and then the tubing as anti-reflux, and finally your pumps are connected to the electricity or it has adequate battery level so you don't have a pump failure middle of the case. Okay, 2% positive confirmatory check. That's why we say you have to teach your GNS as well so they can complement your checking, okay, before starting infusion. And this is why monitoring is very important in Tiva. Accidental awareness during general anesthesia can occur in inhalational, also in Tiva, but the risk is even higher when you use Tiva, and even become twofold when you use Tiva with neuromuscular blockade, because when the patient may be aware, but since you paralyze the patient, the clinical clinical vital parameters might not be showing that the patient is actually awareness. So Tiva, when used with NMBDs, neuromuscular blocking drug, increases the overall risk of AAGA approximately twofold. NAP is National Audit Project 5, UK. Every year they use a National Audit Project. Final year student must know NAP from 1 to I think now already 7. Okay, it talks about, one is talk about anaphylactic, and one to talk about arrest on table, one talk about awareness. So final year student must know all of these. These are called National Audit Project. This may be increased further with non-target control infusion. You see, if you're using Tiva with neuromuscular blockade, the risk of awareness is high. If you're using Tiva but you're not running TCI, you're using a specific rate or mass rate infusion, the risk of awareness is even high. When employing Tiva, the following precaution will help to minimize or mitigate the risk of AAGA. Careful checking, propofol and opioids are clearly labeled, syringed out. Where practical, administration tubing should be visible. Cannula is attached properly, suitable high pressure. The pump should have a high pressure alarm, so we know when there is a kink, when there's a drug is being bung, the line is bung or what. One way valve, anti-reflux, use of specific depth anesthesia monitoring, especially BIS, has to be used. Okay, that's all regarding the discussion on exam-based question discussion. So I hope everyone is clear. So we will end the tutorial now, and thank you. I will